Now let's get into the bigger one, namely cholesterol. And we'll just go through two families of anti-cholesterol medications. Now, they act through different ways, and these are the PCSK9 inhibitors and the statins. They act through different mechanisms, and we'll get into each of them. But again, they are built on the idea that cholesterol is synonymous with heart disease. I just feel inclined to mention that as a biomedical scientist, the precise series of steps that takes a person from cholesterol, or to be more specific, LDL, the lipoprotein that is carrying cholesterol and other things, the precise series of events that takes us from LDL to plaque formation is very unclear. It is not known that this step leads to next step 2, which leads to step 3, which leads to step 4. The general view is, which is ridiculously oversimplified and I would say very problematic and incorrect, is that you have a high level of LDL, and then the LDL penetrates the blood vessel wall. Why? Who knows? Let's not ask that question. And then as the LDL penetrates the blood vessel wall, it then gets engulfed by a macrophage. Why does the macrophage do this? Well, don't ask that question. We don't know. And then the macrophages get really loaded with all of this fat from the LDL cholesterol, and they become very pro-inflammatory foam cells, and they keep recruiting more and more macrophages, and all of this begins to constitute the core of a plaque. And then the plaque grows and eventually occludes a coronary artery, and now the person has a heart attack. That is the general view. And yet, there's significant evidence, just to find one flaw in this description, that if you take an LDL particle and incubate it in a culture of cells, incubate it with a macrophage, the macrophage will do nothing to it. This is work, in fact, from Nobel Prize winning fellows at the University of Texas, San Antonio. Last names Brown and Goldstein. They're legends. They found that native or unaffected, unchanged LDL elicited no effect. The macrophage ignored it completely. But the moment the LDL molecule was somehow altered, like, for example, through peroxidation, which is sometimes people refer to it as just oxidation, but I like to use the term peroxidation, then all of a sudden the macrophage sensed the LDL as problematic and engulfed it. Now, what gets peroxidized? Well, not fats can get peroxidized, but not all of them to the same degree. For example, saturated fats do not undergo peroxidation. Omega-6 polyunsaturated fats undergo peroxidation so readily that you actually have to try to mask the smell of that peroxidation, the rancidity of it, when you buy a bottle of it. So-called vegetable oil, more accurately called refined seed oils like soybean oil or canola oil, etc. Those are enriched with this omega-6 polyunsaturated fatty acid, linoleic acid. So in other words, what I'm implying here, and now stating explicitly, the composition of the fats within the LDL molecule itself are very, very relevant. Now, another feature here, and that actually becomes relevant in one of these drugs that we're going to discuss. Another aspect to this is why the LDL is even within the wall of the blood vessel in the first place. Now, I'm not arguing that if you go in and root out a plaque, you'll find LDL particles there. But why are they there? And to explain this, let me just ask you, if you were naive, unfamiliar to the world, you were an alien comes down. Let's not address it to you, second person. Let's say an alien comes down from space, and they see, among all of the things they observe, that anytime there is a house on fire, there's a big red truck parked out front with flashing lights. What might the alien conclude? If every time they see a burning home and they see the same type of big red truck with big flashing lights out in front of it, well, they may conclude that that big red truck is causing the fire every time. But You obviously see the problem with this because you know the cause and consequence, and you know that the burning fire is actually what's bringing the big red truck with its flashing lights to the home in the first place. But it didn't start it, it's reacting to it. Now, let's bring that back, perhaps a poor metaphor, to the blood vessel and the plaque and the LDL. Why is the LDL there? The assumption is it caused it, and so we have to wage war on LDL cholesterol in the form of these two drugs that I'll get to. However, what if an alternative paradigm is that the LDL is there because of an injury to the blood vessel wall? Now, why would I say that? If you were to go in and root out that plaque, yes, you could detect some LDL, but you would also find likely multiple infectious pathogens, bacteria. And so another view of plaque formation is that it is simply an immune response. That you basically have an infection in that particular spot. It's like a scab of an infected wound. So again, there's very strong evidence to suggest that when you go into a plaque, there are numerous, often numerous infectious bacteria there. So you have an infection. Now, what does that have to do with LDL? LDL is known to have the ability to bind bacteria and remove them from the blood and dump them through the liver out of the body. This is important, and we see this at a whole body population level. The people with the lowest LDL levels are multiple, even 10 to 20 times more likely to have serious infections, like sepsis, which is a life-threatening level of infection. That's because LDL, as much as we have talked about it in the context of heart disease, it is perhaps more relevant in the context of the immune system. And again, its ability to bind and clear bacteria. So perhaps, again, to finish this discussion and get onto the drugs, my original point, perhaps the LDL is at the plaque in order to try to remove the infectious bacteria, the pathogens, rather than causing the problem. Anyway, that's just an alternative paradigm as we get into the interventions to wage war on LDL. Perhaps we shouldn't. All right. Now, the first of these two classes of kind of anti-LDL drugs is the PCSK9 inhibitors. This involves a handful of drugs, and they typically end with the suffix QMAB, like alirocumab. If you see that suffix QMAB, it's generally going to be a PCSK9 inhibitor. And they are a class of drug to lower LDL cholesterol. And the specific PCSK9 is a protein that plays a role in cholesterol metabolism. It will bind LDL receptors on the liver. And by binding the LDL receptor on the liver, it forces the LDL particles to stay longer in the blood. So normally, the LDL receptor on the liver will bind LDL and pull it in, removing it from the blood. That's normal. Rather, that's with PCSK9. That's what it wants to do. PCSK9 wants to help that receptor work. PCSK9 will promote the degradation of the receptor. And so if you have more PCSK9, you have fewer receptors, and then LDL levels would be higher. If you have a PCSK9 inhibitor, you're blocking the function of the PCSK9 protein. And by inhibiting PCSK9, the drugs will increase the number of LDL receptors. So you're freeing up the LDL receptors. Now it can do what I erroneously alluded to a moment ago, which is now it can bind the LDL and pull it in more readily, thereby lowering or enhancing the clearance of the LDL from the bloodstream. So overall, LDL would go down. So it works in that regard. It is effective at lowering LDL cholesterol levels. Now, interestingly, as is the case here with all the other drugs, any studies you see that report an improvement in heart disease risk, look at who they're funded by and look at the absolute risk reduction rather than the relative risk. If they say the use of these drugs reduced the risk of heart disease or a myocardial infarction by 40%, that probably means it took it from a 0.6% chance to a 0.4% chance or something like that. So it might have reached a point of statistical significance, but as my mentor taught me many, many years ago, significance is not always the same as meaningfulness. Nevertheless, that's how the drug worked. Now, the side effects with regards to insulin resistance, there's a little bit of evidence. There was a paper published in 2017 that was a meta-analysis. So that's powerful because that means it's reviewed every study. And it looked at the effect of the PCSK9 inhibitors versus placebo on insulin resistance. And they found, or markers of that, and they found that the use of these drugs did result in a significant increase in plasma glucose and HbA1c. Now, they, of course, had to emphasize that it was small, but it was statistically significant. And so we are obligated to note it, just like I noted the relative risk reduction earlier, where it's often significant. So there is evidence that it's not great, that it is making some degree of measurement of insulin resistance and diabetes risk worse. Now, unfortunately, there's also a complication with mitochondrial function. By altering mitochondrial function somewhat, it's actually, these drugs appear to increase the production of reactive oxygen species. And these then are enabling the production of oxidized LDL. And so there are some reports to find that PCSK9 blocking can increase oxidized LDL levels, and in fact, in one particular study, directly contribute to some damage to the heart muscle, the myocardium. So pretty risky trade-off. You're doing all of this to reduce LDL cholesterol levels, and you may be, in fact, hurting the heart muscle itself.